AMAAC. Now here we are going to start the session about Dieu, updates, ASCO guidelines. Best of ASCO, our first speaker, Professor Ali Shamseddine, is a professor of the Oncology, Medical Oncology Center, American University from Beirut, Lebanon. Dear Professor Ali Shamseddine, welcome, and we are very eager to learn and to listen to your excellent presentation as usual. Please, have the mic.
Thank you, Mr. President. And I want to thank you, Dr. Farhat and Khatib for inviting me for this webinar. So today we'll talk about the if you can give me the control.
Okay, you have the control now, Dr. Shamseddine.
But it is not moving.
Okay, just a second.
So this is my disclosure. It's not moving, no? You will move it, or
we will move it from our side. Please start.
Okay, so we'll talk about the epidemiology of prostatic cancer. In short, this is the data published in 2018, and you can see that the higher incidence in the Oceanic group, followed by North America and Europe, as the lowest incidence, as you can see, in the Africa, followed by Asia. Next, please. And according the data published 2014 and the projection in 2020, as you can see here, we have a tremendous increase of the prostatic cancer incidence from early 1998, representing 21 per 100,000, in 2008 reaching around 40 per 100,000, and we expected in 2020 to reach more than that, reaching between 50 to 69 per 100,000. Next, please. So I will start with the case presentation. This is a 63-year-old male patient presenting with increasing lower urinary tract symptoms, and DRA at that time revealed an indurated gland with abnormal architecture, and the PSA was at that time 21 nanogram per ml, and MRI of the pelvis shows a bilateral disease in the prostate with extracapsular extension involving seminal vesicle, and there is no nodal involvement. Next. So a biopsy revealed Gleason score 4+5, 9 means total in 13 of 16 cores bilaterally, and the bone scan at that time did not reveal any disease in the bone, so it is an M0. Next. The patient underwent surgery at that time, and following the surgery, the PSA was undetectable. In 2011, he has a rise on the PSA, but negative CT and bone scan, and he had at that time salvage local radiation therapy, and his PSA went down again. In 2014, his PSA rose again with no detectable metastasis on imaging, and he had salvage ADT as continuous treatment. And in September 2018, his PSA started to rise with a doubling time of around 8 months with testosterone level less than 50 nanogram per deciliter, and still no detectable metastasis on imaging. So this is what we call the non-metastatic castrate-resistant prostatic cancer at that time. Next. So the patient was started at that time on enzalutamide in addition to ADT, and his PSA become undetectable 6 months after starting the treatment till date. So this is the simple example of the patient with the non-metastatic castrate-resistant prostate cancer, which encountered just an increase in the PSA without any radiological evidence of disease and a doubling time less than 10 months. Next. So this is the patients with the schematic presentations when they have castrate resistance. Usually they start or present with rising PSA and a castrated testosterone level, as you can see here. And the patients can present it earlier with only biochemical relapse, which without any metastatic disease. And they can progress later to metastasis without any symptoms, and then they become symptomatic. And the time lapse may extend up to 60 months until the death. So we have a lot of varieties of patients with castrate-resistant prostatic cancer. They are not one disease, so they have to categorize these patients into subcategories and to deal with each category according to the presentation. Next. And this is how do I treat these patients. And usually those patients, when they present either early, whether the treatment as a localized disease with curative intent, and these patients either they don't relapse or relapse, and they start by rising PSA only, and either PSA only or local or distant metastasis when they relapse. So part of patient with intent to treat for curative intent, they will relapse also, and relapse either by rising PSA, and this is the non-metastatic, again, castrate-resistant, or de novo, they start to have a non-curative intent from the start as hormone sensitive, then they become hormone resistant, but with rising PSA only. So this is another group with non-metastatic castrate, and usually they have a shorter survival, those category of patients. Next. So before 2018, those patients, they always, as a recommendation from all the guidelines, we don't actually treat these patients, non-metastatic castrate-resistant, outside clinical trial. And starting 2018, July, then February, and then July 19, we have 3 drugs that are approved by FDA for the treatment of these patients, and those demonstrating a positive impact on outcome, prolonged time to metastasis, and newly is survival. And the recommendation to treat these patients now is strong rating, as you can see here. Next. Why to treat these patients? This is what they call the rationale for intensification of androgen receptor signaling inhibition. Whenever you use the androgen inhibition, always this time is not a complete inhibition. We have several levels of inhibition. The inhibition of the production of the androgen, and this is at least on several levels. And we have the mural tumor production of the androgen. And we have the sensitivity of the receptors. Even with the castrated level, the sensitivity is there of the receptors at the lower level of the androgen. So it is important to continuous inhibition of this androgen, either by deplete the sites of production or inhibition the sites of stimulation. And the combination of multiple drugs will lead to the complete inhibition of this androgen, either the production or the deprivation of the receptors, so prevent the downstream signaling through the nucleus to the nucleus, and this will affect the survival and proliferation by inhibiting the cells, and the cell growth will be inhibited. Next. You can see that this continuous androgen deprivation is not limited to one stage of prostatic cancer. It is now spreading through all the stages of prostatic cancer. We have the metastatic hormone sensitive, as you can see from these 3 drugs and 3, 4, 5 trials, and the metastatic castrate-resistant, and we agreed previously on the 2 drugs, mainly from at least 4 randomized trials prior to chemo and after chemotherapy. And now we have the approval in the non-metastatic castrate-resistant prostate cancer from the 3 main trials, which is the SPA, the PROSPER, the SPARTAN, and the ARAMS trial. Next. So these are the 3 trials, the SPARTAN, the PROSPER, and the ARAMS trials. The use of 3 drugs, the SPARTAN, the apalutamide, the PROSPER, the enzalutamide, and the ARAMS is darolutamide. You can see that the primary endpoint of the 3 trials are the metastatic-free survival, consistent in all the 3 trials. And the secondary endpoints, they are variable, as you can see here, but what is important is overall survival is one of the secondary endpoints also. Remember, this is not a head-to-head comparison, and the trials cannot be directly compared. Next. So we start with the SPARTAN trial, which, as you can see here, tested the apalutamide 240 milligram QD with ADT versus the patients on placebo. In patients with non-metastatic castrate-resistant with a baseline rising PSA only, equal more than 2 nanograms per ml, and doubling time PSA less than equal 10 months. And the MFS is the primary endpoint, and you can see there is a significant improvement in metastatic-free survival with a hazard ratio of 0.28 and p-value less than 0.0001, 40.5 months versus 16.6 months, with a 24 months improvement in metastatic-free survival benefit in favor of the apalutamide. Next. And what is important in the apalutamide study is we have the progression-free survival 2, means the progression after the first and new subsequent therapy, then the second progression-free survival significantly improved in favor of the apalutamide therapy with 15.6 months versus 43.8 months, hazard ratio 0.68 and p-value less than 0.0001. And the most commonly received subsequent therapy in this group is the abiraterone prednisone, as you can see here. And for intended to treat population in the placebo group, 69% received subsequent therapy. In the apalutamide group, only 40% received what they call the life-saving therapy subsequently. Next. Again, for the SPARTAN trial and presented recently in the ASCO 2020, you can see that the time to receive cytotoxic chemotherapy is prolonged in the patient who is receiving apalutamide compared to placebo group. significantly with the hazard ratio 0.63. And also the PSA progression is prolonged in the apalutamide group, 40.5 months versus the 3.7 months in the placebo group with the hazard ratio of 0.07, significant p-value. And the also symptomatic progression is prolonged more time with the apalutamide versus placebo group, hazard ratio 0.57. And a second progression or death also prolonged with apalutamide. We have 55.6 months versus 41 months in the placebo group. Next, please. And recently in ASCO 2020, we have the overall survival. You can see significantly prolonged with apalutamide, 73.9 months versus 59.9 months in the placebo group with a hazard ratio of 0.76 and significant p-value. Next, please. So the second trial is the Prostate trial using enzalutamide as the experimental drug, 160 milligram per day plus ADT versus placebo in patient non-metastatic castrate-resistant prostate cancer, rising PSA only. Again, PSA equal more than 2 nanogram per ml and PSA doubling time less or equal to 10 months. And again, the same metastatic-free survival is the primary endpoint. And you can see there is significant improvement, copy-paste from the previous trial of the enzalutamide, 36.6 months versus 14.7 months. Again, hazard ratio equal almost 0.29 and p-value was significant, and 22 months improvement in metastatic-free survival in favor of the enzalutamide, 71 reduction of the distal progression. Next, please. And you can see here the time to first use of subsequent antineoplastic therapy is continuously prolonged with the use of the enzalutamide, 66.7 months versus 19.1 months in the placebo, with a hazard ratio 0.29 significant p-value. Next, please. And also from the ASCO 2020, you can see the overall survival. Here is significantly prolonged with the enzalutamide versus placebo group. Again, a hazard ratio of 0.73 compared to the previous one, the apalutamide with 0.78. Next, please. And the third trial, the ARMS trial, as you can see, using darolutamide with the 600 milligram PID, the same group of patients, non-metastatic castrate-resistant prostate cancer with rising PSA equal more than 2 nanogram per ml and PSA doubling time equal than 10 months, and the same primary endpoint, MFS. And also you can see significant improvement on MFS reaching 40.4 months for the darolutamide versus placebo, and 22 additional benefit of MFS and 59% reduction risk of metastasis. Next. In the darolutamide group, there is an interesting testing for the time to pain progression, which was not mentioned in the previous two trials. And this is important for the patient. So the time to pain progression is significantly improved with the use of darolutamide and compared to placebo with a hazard ratio of 0.65. And also for the time for the first cytotoxic chemo is significantly improved as in the case of apalutamide group. And time to first symptomatic skeletal events also is significantly improved with the use of the darolutamide. Next, please. And again, the overall survival presented in ASCO 2020, we showed a significant improvement in outcome as survival. 36 months estimated for the darolutamide, 83% alive versus 77% in the placebo group. And the other ratio 0.69 with significant p-value, as you can see, as positive trial for this as survival. So all the trials give the same outcome as survival, but you can see the other ratio here is much better with reduction of around 31% in that rate compared to other ratio of 0.73 and 0.78 in the other two trials. But again, this is, you cannot compare trials. And this is recently about the systemic review of the meta-analysis of the 3 trials showed the pooled risk ratio for any grade of adverse event or more than grade 3 or grade 5. And you can see here, there is no significant associated increase in risk of death due to any adverse event. Next, please. So we have the 3 trials, and they have the same primary endpoint, and they have the same survival with some difference. What about the chemical structures for the 3 trials? If you look for apalutamide, enzalutamide, they are equally, looks the same chemical structures. But darolutamide is differently as a chemical structure. And this sometimes explains why the enzalutamide, apalutamide, they can cause or cross the blood-brain barrier versus darolutamide will not cross the blood-brain barrier. Next. So when you look about the primary endpoint of the trial, the population, they are the same population, median metastasis-free survival, and the benefit is almost the same, 22 versus 24 months. And overall survival, though we get some improvement in the ratio with the darolutamide compared to the apalutamide, but again, you cannot compare these trials because it is not head-to-head comparison. If we cannot compare the efficacy and survival, what about the toxicity profile from the 3 trials? So based on the side effects, as we said, the darolutamide is the least to go to the brain compared to the enza and apalutamide. So you can see here the falls with the SPARTAN is 22 versus 10, and the PROSPER is 18 versus 5. But here you can see it is comparable with the active drug versus the placebo. Here you see the difference. So the rash also more with the apalutamide, more prominent, but you can't see this rash with the enza or with the darolutamide. So based on these issues, you can see the hypertension more with enzalutamide and not seen with APA and the darolutamide. So based on that, you can also choose the drug based on your patient and based on some increased toxicity for one drug versus the other. So the enzalutamide, you can more have a musculoskeletal effect, 34 versus 23. Darolutamide doesn't penetrate the brain versus enza and apalutamide. So very important to have this. And from the data, darolutamide prevent pain progression And this data is the only present from the darolutamide and not from the ABA or enzalutamide. So this is very important when you have the data that the three drugs are the same as efficacy. We can choose some of the drug based on your patients, based on the performance and the comorbidities, and choose the right drug for the right patient. Next, please. So darolutamide associated with significant reduction in select adverse events, including falls, rash, fatigue versus alternate variable, androgen receptor blockage like ABA and enzalutamide. And again, associated with significant lower absolute risk for some adverse event, favorable to apalutamide for rash, for falls, rash, fractures, favorable to enzalutamide for fall, dizziness, mental impairment disorders, hypertension, fatigue, and also severe fatigue. Next. Remember that all these patients in the 3 randomized trials used the conventional imaging, means CT scan and bone scan. So what about the role of PET PSMA? And very important, in a recent abstract in ASCO, 37 patients who had early PSA progression during castration, and the high risk represent with doubling time within 10, non-metastatic by conventional, and all patients underwent both gallium FDG and gallium PSMA, and the primary endpoint was the prevalent PSMA FDG disease. Next. And you can see that the median PSA imaging was around 0.57 nanogram per ml. We have 114 lesions detectable in 29 of the 37 patients, with a high prevalence 73%, both node and M+ disease observed. Of the 114, 81 were PSMA dominant, 33 was PSMA negative, but FDG positive. So you may have a change in the histology also. So a short PSA doubling time is very significant, with the odd ratio very high and associated with the high PSMA dominant disease. And also a high Gleason score were associated with the high PSA negative FDG positive disease. And you can see that among these patients with PSMA negative, PSMA negative, but FDG positive, rarely detectable in those patients with hormone cell cohort, but always detected in castrated patients. And this denotes some patients transforming to a higher grade, or the poorly differentiated group, or maybe the neuroendocrine group. Next. So using the PSMA or PET FDG, there will be a high prevalence of N+, M+ patients, with significant patients among them. 1/3 of these patients, 33%, will have PSMA negative, FDG positive, with an early PSA progression, specifically in the castrated level with the high Gleason, and this is very important. Next. So you can see here the role of PET PSMA is becoming more prominent, but also the role of PET FDG in castrated patients, specifically those with a high Gleason. As you can see here, this is a patient with a negative bone scan. Next. And you can see the PET, no, please. You can see the PET PSMA and the same patients, very active metastatic disease if you compare bone scan to PSMA. And it is coming. Next. So in conclusion, all three of the randomized phase 3 trial that evaluate ADT plus either apalutamide, enzalutamide, or darolutamide showed response rate more than 90% time to disease metastasis or death was significantly improved with a risk reduction of approximately 6 to 70% and maintain quality of life. And recent results showed that significantly improved overall survival. The three drugs, giving these drugs to the patient with prostate cancer with no detectable metastasis lesion and PSA doubling time equal more than less than 10 months despite ongoing ADT is effective and should be considered standard of care. Thank you.
Thank you very much, Professor Shamseddine, for this excellent presentation. And I think now going for the panel discussion with Professor Ola Khorshid and Professor Marwan Al-Aksha. Are they joined us or not till now? But while they're joining or for the discussion, we already see the time, but the technical issues took at least 3 to 4 minutes. There are 2 questions, Professor Shamseddine, for you in the questions zone. Yes. You can check it in the question and answers from Ahmed. Ahmed, that is absolute PSA doubling time considered an indication for changing treatment or should be a rhetorical response. And if apalutamide was used before chemotherapy, then patient got disease progression after chemo, is there any data to reuse barbiturate again?
So we have 2 parts of the question. Is the absolute PSA doubling time considered as an indication for changing treatment? In those patients, as we know, in the 3 randomized trials, we took only PSA doubling time as a decision without radiological evidence of disease. So those patients has no, by conventional image, CT and bone scan, they have no disease, no metastasis, but only rising PSA. So the doubling time was the measurable one. The second one, if abiraterone was used before chemotherapy, I'm not sure what does it mean, because if abiraterone is used in the hormone-sensitive disease, but this is non-metastatic patients.
Yes.
So in patients with the STAMPEDE trial, there is a small category of patients that M0, sometimes we decide if they have high risk M0 disease that we may use abiraterone to this category of patient as adjuvant for 2 years, for example. But this patient did not included in these trials. So chemotherapy also, I'm not sure that this category of patients received also chemotherapy. No chemotherapy in this category of patients.
Okay, thank you very much. I think now we should go forward for the second presentation. Professor Joseph Kattan, he's the head of Hemato-Oncology department at Lebanon. We are eager to listen to you, Professor Joseph, and welcome. Now you have the mic. And then if any other questions, we're going to be at the end of the whole panel. Welcome, Professor Joseph. Your mic is, I think, okay.
Okay. Yes. You are hearing me now? So,
yes, yes, you are hearing.
Thank you, Mr. Chairman. Also, thank for the panelists. Thanks also for the organizers, Dr. Sami Khatib, Dr. Fadi Farhat. And my presentation will focus my presentation on the maintenance therapy And please mute your phone because there is music somewhere. Thank you. So my talk concerned the practice changing in maintenance therapy in metastatic bladder cancer. But I have to start with a case presentation talking about a classical case of metastatic bladder cancer. It's a real case that we treated a few months ago. It is a 56-year heavy smoker man. He lived outside the capital, and he had 2 episodes of hematuria with 2 negative cystoscopy. The hematuria and cystoscopy were done in March and April 2019. We will see why there was negative cystoscopy in this particular man. At the 3rd episode of hematuria in August 2019, that means 5 months with the waiting time, the urologist at our department or at our institution performed a total body CT scan, and he discovered a bladder diverticulosis. So this is the reason why the 2 previous cystoscopies were negative. But unfortunately, in the PET scan, there were pelvic lymph nodes enlargement around 3 centimeters with multiple bone lytic lesion. So the lost time of 5 months rendered this disease metastatic. The urologist, he was aware about the diverticulosis, performed the 3rd cystoscopy. He looked very carefully. He went into one of the diverticuli and found the primary. It was an infiltrative, undifferentiated urothelial carcinoma. So we are now in front of metastatic disease, and I performed the renal function, and the clearance of creatinine was 65 milliliter per minute. So according to the recommendation, we started the chemotherapy, the most popular protocol, gemcitabine plus cisplatin, and the chemo started in September 19, 2019. 3 months later, in December 2019, he received 3 cycles of gemcitabine cisplatinum, and there was a disease assessment showing a partial remission with reduction of the size of lymph nodes, of the bladder thickness, and even some kind of healing of lytic lesion. In February 2020, at the end of the planned chemotherapy, he received already 6 cycles of gemzar cisplatinum, and the disease assessment confirmed the maintenance of the same partial response. What to do now? We have a controlled disease with maintained partial response. Usually in our daily practice, what we do, we take a break, and we offer to the patient one of the most used options, holidays. So I discussed with the patients the holidays. He agreed. He was very grateful because he can go to his home. He has a lot of toxicity, and we continue to perform the surveillance. April 2020, almost 2 months after the end of chemotherapy. So it was a very short free interval. The patients complain of lumbar pain, and the assessment of the disease, I told him to perform a CT scan. The CT scan showed a bilateral hydronephrosis with increase in the size of retroperitoneal lymph nodes, as well as increase in the bone metastasis. The creatinine clearance decreased to 30 milliliter per minute. So the patient was hospitalized. I'm talking about April 2020. He was hospitalized. there was 2G put in his urinary system. The creatinine clearance dropped to 40 milliliter per minute. So there still remains some kind of chronic renal insufficiency. And what I suggest for him in this situation is second line, the ICI monotherapy, any kind of immune checkpoint inhibitor was approved in this situation. So I prescribed for him the immune checkpoint inhibitor, and first report was done, second report. So we have to convince the third party payer to reimburse the drug. So we lost around 1 month. And meanwhile, around June 2020, because we lost time between the hydronephrosis, the G, and the request of the drug, in June 2020, the performance status deteriorated. He was 3, cachexia. There was no immune checkpoint prescribed, and the patient was referred to palliative care and died in the same month. So sorry, it's a sad story. But I looked somewhere to see if we have done something wrong in the procedure of our treatment. We followed the recent recommendation. So this recommendation was presented at the GU ASCO in February 2020. So till now, I don't think that something has changed. The patient was a cisplatin eligible when it was metastatic. He was treated with platinum and gemcitabine, and after 2 months of off therapy, there was a new progression, and the patient get the ICI. So if we look, all are in the according to the recommendation. But if I want to criticize our concept of treatment, I'll go back to the second slide of the case presentation. When the patients in February 2020 finished his 6 cycles of gemcitabine and cisplatinum, he was in partial remission, but we were aware, we are as physicians aware that it's some kind of time bomb. The disease will recur as soon as possible, and it will be unpredictable, because we know this type of bladder cancer with their fulminant progression. So it's the most probably the treatment holidays is not a good option in bladder cancer. And even what we can do maybe to give earlier the second line and to go to maintenance therapy. So I think with this classical clinical case, I introduce the value of maintenance therapy in bladder cancer. Let's check this concept of maintenance therapy. This concept is not it's not a recent concept. We know very well that we have positive experience in maintenance therapy in ovarian cancer, in colon cancer, almost with targeted therapy. But the most striking history or success of maintenance therapy was done in non-small cell lung cancer in 2009. So let's go back to 2008, 2009, and let's see some kind of flashback memory. If you remember, this slide was very famous in 2009. We present the classical attitude in non-small cell lung cancer, first line with the first blue arrow, the second line and the second blue arrow, and between the both arrows, we have the break treatment. But the other slide argue in favor of the maintenance between the two first line and second line. We don't give a break, and we give immediately maintenance therapy with the red arrow, which showed a higher progression-free survival and overall survival. And at that time, the concept of holidays in non-small cell lung cancer was completely abandoned. So we canceled the concept of holidays in non-small cell lung cancer. Moreover, we get more deep in the definition of the maintenance therapy at that time, and we separate the maintenance therapy in two parts. The continuous maintenance, when we are giving one of or two of the induction drug as maintenance until progression, we call it continuous because these are the same, or the switch maintenance, that means we introduce a new drug as maintenance following the induction therapy, and we continue this new drug till progression. And if you remember, in 2009, there was a multiple success stories concerning the maintenance. The first one, the docetaxel by Fidias. It was a randomization between immediate docetaxel or docetaxel when a second line until progression. So the immediate docetaxel win at that time, or win in the past, or the GMAN study. The GMAN study, it's the presentation presented by Belani when he used pemetrexate as a switch maintenance after the induction therapy with other drug and platinum. It was also positive, and I remember it was the highest progression-free survival at that time. The third one, Saturn with erlotinib as switch maintenance positive. The fourth one, bevacizumab plus erlotinib, the Atlas. Also, this continuous maintenance was positive. And in 2013, the Paramount study where we used the pemetrexate as a continuous maintenance. So it takes us 10 years from 2009 to 2019 when we published in an editorial in Future Oncology with this question: is there a role for maintenance therapy after platinum chemotherapy in bladder cancer in the era of immune therapy? And we wait 1 year till June 2020, till the ASCO, the plenary session, where Thomas Powles present the Javelin Bladder 100, showing the positive effect of maintenance avelumab after the first-line chemotherapy with cisplatinum in patients who respond to chemotherapy, and it was a practice changing. So I will not discuss immediately this presentation, and I will ask a question, a classical question. Do we have in bladder cancer, before the study of avelumab at the ASCO, do we have any studies concerning the maintenance therapy? The answer, yes, there were few studies. In fact, I looked back in the literature and I picked up 4 studies that I think these are relevant to be presented in the history of switch maintenance therapy in bladder cancer. And it includes 2 negative. The first 2 studies were negative. The first one is a phase 2 where sunitinib, the classical TKI sunitinib, were used versus placebo as maintenance therapy in patients who achieved at least stable disease after first-line chemotherapy. It was negative. The second one, it was a true phase 3. These patients get lapatinib. Why lapatinib? Because they have RB1, RB2 overexpression, and it was negative. So let's have one slide by every study, by these negative studies. The first one presented in 2014. It is the sunitinib versus placebo in patients who achieved any stable disease or any objective response after 4 to 6 cycles of standard first-line chemotherapy. The first graph showed the progression-free survival, median PFS 2.9 with sunitinib versus 2.7 with the placebo. It was a negative study, no difference. The overall survival, 10.5 months with sunitinib in the left of the screen versus 10.3 months with placebo. So PFS and overall survival, no difference between placebo and the sunitinib. And this study was considered negative, not only because of the absence of positive response, but also because there was a sample size. There was only 54 patients included, and it was closed prematurely. The second negative study, it's a true phase 3 study presented at and published in GCO 2017 by Thomas Powles, the same who presented at the ASCO the Javelin 100. In fact, they treated the patients who achieved at least a stable disease by either lapatinib. Why lapatinib? Because these patients have an overexpression of RB1 and RB2 versus placebo. And if we look to in the middle, we have the PFS survival, no difference, 4.5 months versus 5.1 between lapatinib and placebo. Overall survival, no difference, 12.6 months versus 12 months. So it was a negative study, and this trial did not find any significant improvement in outcome. So let's move to the other two studies. These other two studies, the venflunine versus best supportive care and pembro versus placebo, were positive studies. So we have in the literature positive experience with maintenance therapy. Let's take a look on the venflunine study. It's called the MAJA study. Patients who achieved at least stable disease after 4 to 6 cycles of cisplatinum and gemcitabine, they are randomized between the venflunine. Venflunine is a Venca alkaloid approved in second line and in metastatic bladder cancer. They received the venflunine standard dose, 320 or 200 or 280 milligrams per square meter every 3 weeks versus best supportive care. There were 88 patients randomized, 45 to venflunine and 43 to best supportive care. And the primary endpoint was progression-free survival. Here are these curves of progression-free survival and overall survival. It was a positive study. The median progression-free survival of venflunine, 6.5 months compared to 4.2 months in the best supportive care. You can see the slides to the left and the difference between the two. It was positive study. Concerning overall survival, it's not the primary endpoint. However, there is a trend in the difference, and the number of patients was not enough to show the difference. However, we have a different a separation in the curve, and the median overall survival of venflunine is 16.7 compared to 13.2 of best supportive care. Why this study was neglected? Because the study deal with a drug like venflunine not approved in the USA. So there was no impact of the study in our practice. Let's move to the second positive study. The second positive study is a phase 2, and here we have the pembro. So avelumab was not the first. Pembro was used before versus placebo. These patients have at least partial response or stable disease and were randomized. The only problem that it's a phase 2 and not a phase 3, and we will see some slides concerning the study. The study was presented at the ASCO 2019, presented in the oral session by Matthew Glasky, and the title was randomized double-blind phase 2 study of maintenance pembrolizumab versus placebo after first-line chemotherapy in patients with metastatic urothelial cancer. It was not a keynote study. It was conducted by a private group, the Hosher Cancer Research Network, GU 14182. This is the study design, almost the same that we will see with avelumab. Patients who have a stable disease, at least after less than 8 cycles of platinum-based therapy, they were randomized down to placebo, to pembro, 200 milligram every 3 weeks, up to 24 months, not till progression, for 2 years only, compared to placebo every 3 weeks for 2 years. And there was something special in the study. The authors allowed the crossover. When patients progress on placebo, they have the right to be treated with pembrolizumab. So this crossover could harm the result of overall survival. However, in the ASCO 2019, they report two variables only: the progression-free survival and the response rate. And the progression-free survival was positive. So if we look to the rectangle red down in the graph, the placebo arm include 52 patients, the pembro arm 55 patients, and the difference in PFS was significant. Median PFS of the pembro was 5.4 months, and the median PFS of the placebo 3.2 months. So there is a difference of 2.2 months, which is enough, with a p-value of 0.038. But also we have another interesting thing concerning the response rate. The overall response increased with the maintenance from 12% in the placebo to 22%. Even we have a 9% increase in complete response in the pembro arm compared to 0 in the placebo. The conclusion of the study was that pembro as a switch maintenance is a active drug with prolongation of PFS, but we have to wait the complementary reports concerning the overall survival and the end of recruitment. Also, we have to wait the phase 3, but since 2009, we didn't see any complementary study, any publication of the study till 1 month ago, when we have the Javelin Bladder 100 presented by Paul Thomas in the virtual ASCO. So I will attack this study. Patients who have complete response, partial response, or stable disease with a standard first-line chemotherapy after 4 to 6 cycles were randomized to avelumab 100 milligram per kilogram every 2 weeks plus best supportive care till progression versus best supportive care. There were 700 patients included, randomized 1-to-1, avelumab 350 patients, best supportive care 350 patients. The primary endpoint was overall survival. Also, the overall survival was analyzed in regard of PD-L1 negative or positive. And here we have the patient's characteristics. There is a well-balanced characteristics between the two arms. If we look to the overall population, the median age is the same between the two arms. The upper tract tumors were present in 30% and lower tract in 70%. Visceral metastasis in more than 50% in both arms. PD-L1 positive in around 50% in each arm. The first line treatment, either with cisplatin or carboplatin, are the same. And the best response to chemotherapy, either objective response or stable disease, we have the same percentage in both arms. And here we have the primary endpoint. The overall survival. To the left, it concerns the whole population. The difference between the curve is obvious. The median overall survival of the avelumab arm, 21 months compared to 14 months with best supportive care. The p-value was less than 0.001. If we look to the right and we consider only the patients who have PD-L1 positive, more than 50%, these patients also has a a higher magnitude of response. Avelumab non-rich and best supportive care 17 months. The benefit of overall survival was consistent in all subgroups of patients, whatever the ECOG performance status, the best response to chemotherapy, with visceral, without visceral, PD-L1 positive, negative. Donc, all these subgroups have the same benefit from switch maintenance avelumab. The PFS was also reported. it was a secondary endpoint. And to the left, it's the PFS for the whole population, and the right for the PD-L1 patients. In the whole population, the median PFS with avelumab was 3.7 months compared to 2 months. And to the right, to the PD-L1 patient, the magnitude was higher also, 5.7 compared to 2.1 months. What about the consequent treatment? These, what about the objective response? Objective response, it was higher in the patients who received avelumab compared to best supportive care. So if we look to the first line, objective response rate increased in 9.7% in the avelumab, while it increased only in 1.4% in the best supportive care. And here we have an increase in complete response around 6% in the avelumab versus 1% in the supportive care, and partial response around 4% versus 1% in the best supportive care. For the subsequent therapy, and here it's obvious that patients on the best supportive care will receive higher amount of subsequent therapy, 61% versus 42%. And if we look to the amount of PD-L1, PD-1 inhibitor used subsequently, it was used in 43.7% in the best supportive care compared to 6.3% in the avelumab arm. Concerning the toxicity or the safety of the drug, so certainly avelumab presented more toxicity compared to the no therapy. And however, the grade 3, if we look to the grade 3 in the second column, the percentage of patients who suffered from grade 3 are always less than 2%. And there was, however, 2 deaths in the avelumab arm, and the death was related to most probably something unrelated to the drug. One died for sepsis and the other from ischemic stroke. Now we move to the immune-related adverse event. Also, we have around 7% of grade 3 avelumab toxicity, but if we look to grade 3 for each organ, we have less than 1% in the hypothyroidism, pneumonitis, and the authors have to use, or the investigators have to use corticoids in 9% of avelumab treated patients. So I come to the conclusion. It was clear that yes, the javelin maintenance 100 showed that there is a gain in PFS and overall survival when we used avelumab as a switch maintenance. The safety profile was very good. And the most important conclusion, avelumab first-line maintenance in patients whose disease has not progressed with chemotherapy represent a new first-line standard of care for advanced urothelial cancer. Thank you for your attention. Thank you.
Thank you. Thank you very much, Professor Joseph Kattan, for this excellent presentation. Very detailed and clear. Thank you very much. Let me here give welcome to Professor Bayer Sarkis. He's the president of the Lebanese Urology Society from Lebanon, and also the panel modulator, Professor Basim Al-Bahraini, Director of National Oncology Center, Royal Hospital in Oman. Welcome, Professor Bayer, and welcome, Professor Basim Al-Bahraini. I think both of you joined this meeting now. And here is the panel discussion, and you have the microphone for the attendees and the others to have their questions. Welcome, Professor Basim Al-Bahraini, and welcome, Professor Bayer Sarkis.
Please, I would like to welcome also Dr. Deborah Mukherjee from the American University Center, who is the panelist with us, if you allow me, Dr. Maki.
Yes, yes, welcome. Yes, it's our pleasure to see you, Professor Mukherjee here. Welcome. And you can share with us in the panel discussion here. You have the mic now to modulate the questions and the different answers. And if you have any participation or added value information or knowledge, please, you have the mic now.
We've had a really interesting question from Dr. Jacqueline to Dr. Kattan. In the area of person, what's the importance of genetic testing in your case? I think that's a great question. What do you think, Dr. Kattan?
In the era of, I didn't hear well.
Personalized medicine. Yeah. What is the role of genetic testing?
Certainly, there is a big place. So, but to conclude now, it's very early. We are treating more and more our patients concerning the molecular classification, and now with a lot of mutation, maybe we get to what we call personalized treatment. Till now, the experience with RB2 was negative, even for patients who are RB2 positive. There's no practical impact in the treatment. Certainly, it's the future for everything, but till now, do we have any target like PD-L1 or something else to predict the value of maintenance therapy or immunotherapy in the maintenance setting? It's very early, but it's the future, I think.
Absolutely. I guess in the metastatic setting on progression, we now have erdafitinib for FGF mutations and fusions. That would be the only role that I could think of. And of course, for fusions, the NTRK fusions, we could potentially think about targeted therapy. But that's a really interesting question. We have a second question about the role of taxanes as maintenance therapy in place of immune checkpoint inhibitors. Would you like to comment about any data for taxane maintenance after platinum?
One of the drug approved in second line are in metastatic bladder cancer are taxane, and we have more studies concerning Taxol as second line. If we are thinking like the venflunin, if there is any study or design using taxane as second line as maintenance therapy, we don't have data. Certainly in the literature, we don't have data, but the concept to use taxane as maintenance therapy, let's say with a smooth dosage and weekly dosage after in patients who have stable disease, at least after first-line chemotherapy, it's some kind, let's say, an interesting concept, but we need the practical study to confirm this concept.
Absolutely. So no data at the moment for taxanes in maintenance, but certainly for second line, if a patient does not have access to vinflunine or immunotherapy, that would be an option. We have a question from Dr. Hatton. Perhaps I can address it to Dr. Bassem. A question about the use of immune checkpoint inhibitors. Do we need to check PD-L1 positivity in first and second line? Dr. Bassem.
Yes, it depends on the center. If it's available, we need to test it, but if it's not available, then there's no other choice. As you say in this trial, the people who got PD-L1 positivity, they have better response than the one who don't have it. So for us, we prefer to do it, and that will help us in two things. First of all, to get a better response to people, and from the health economics, because if you want to reduce the budget of using immunotherapy because it's quite costly and the patient cannot afford, then if you have positive tests, that will give more convincing the patient to spend money on those medications.
Yeah, a very good point. Dr. Kattan, and in a word about PD-L1 testing.
Yeah, if we want to go by the book, by the recommendation, so the recommendation are to test the PD-L1 and treat PD-L1 positive are only in unfit patients first line. Correct. So in second line metastatic, it's effective, and the indications are regardless of PD-L1. Even in maintenance therapy, we have the positivity either in positive and negative. But I agree with that the amplitude or the magnitude of response increase with PD-L1. So for the, let's say for financial matter, we have to choose maybe in our countries, we have to select upon the positivity of PD-L1. But if we look to the literature, to the approval, to the recommendation, only PD-L1 positive for patients for unfit in first line.
Absolutely. So this answers Dr. Rahim's question about first line atezolizumab and pembrolizumab in in cisplatin unfit patients, you need to test. However, in second line, we have approval for everyone. And I know Dr. Farhat is very interested in pharmacoeconomics, so that would be a really nice study for everyone in the region to do, particularly about PD-L1 testing and bladder cancer treatments. So I think we're probably at the end of our time, unless anyone has any other questions or any of the panelists have any questions for Dr. Kattan. It's an excellent and overview of the subject.
Okay, I think here, one of the attendees sent the questions that why you don't go for, he asking like that, why you don't go for just maintenance by gemcitabine? It's a very cheap and available drug. I think he needs from you certain data that you can give us some sort of comparison between what we have available and what in the future we can do the things.
In the literature concerning the bladder cancer, we don't have any data with gemcitabine as maintenance, while in non-small cell lung cancer, we have small studies dealing with gemcitabine as maintenance. And it was some kind of positive study, not overall survival, but PFS, the study was small, but you know, 15 years ago, it was not a big study and it doesn't have an impact. So nowadays, as an option to try a continuous maintenance, giving platinum gemcitabine, then continue with gemcitabine, is an interesting concept. So we need patience, we need to randomize, and so we need some time, and it's difficult to do, but it's an interesting idea.
I don't think we are going to have, because of gemcitabine is out of patency, and the company will never invest on clinical trial using gemcitabine.
Absolutely. So usually it's the sponsors behind these big studies, and no one is interested in gemcitabine.
So any more questions, please, or any more question or presentation? We are coming here to the end of the time now. Please, I would like to remind all of the panelists that we need to fill up the questionnaire for the meeting, please, before you leave. Any question? Any presentation?
Thank you very much all.
Thank you.
Thank you, Deborah. Thank you, Dr. Maki.
Okay, thank you very much for Professor Sami Khatib and Professor Fadi Farhat for giving us this chance to be together while the airports are shut and locked down. And we are happy to see all of you and getting very rich information and knowledge from your wide experiences and from your great collaboration. And I think you refresh our knowledge and increase our abilities now to do more better in the both topic, whatever in the non-metastatic prostate carcinoma or the bladder cancer. And thank you very much for our colleagues in the Science Pro company for this great connection. Thank you very much for the Janssen. Thank you very much for the AMAAC and the Cancer Research Group. Thank you very much for Professor Fadi Farhat for this great organization and collaboration and collecting all of us among this excellent, extraordinary panel and attendees. And we're looking forward to see you near in the coming future activities. Thank you very much.
Thank you. Bye-bye.
Bye-bye.
Bye-bye.